Hello, everyone. Good morning. Thank you all so much for being here. It is a pleasure to be joined by this panel of incredible experts. Dr. Ofadile, I want to start with you. We just watched that video, a powerful video from Olivia Munn about her cancer diagnosis. And I think we all know intuitively that the trajectory of what happens to a person when they're diagnosed with cancer has changed a lot in the last several decades. What is it like now to be diagnosed with cancer, and how is technology changing the outcomes for people?
Thank you so much. It's a pleasure to be here. So I'll say right now, for a person who is getting cancer treatment at a place like Sloan Kettering, we're moving to a world of having more personalized diagnosis. So that means based on your genetic markers, what type of cancer subtype do you have, to personalized treatment recommendations. So what therapeutics, what therapies are best suited for your cancer type to give you the best survival. So we're moving from a world of generalized medicine to personalized medicine. It's aspirational, but we're making concrete steps to get there, and that's happening right here, right now in America.
And Tina, Pfizer has set some ambitious goals for bringing new drugs to the market. What is Pfizer planning in terms of cancer treatment and therapies going forward?
Yeah, good morning, everyone. It is a pleasure to be with you all for this discussion with my esteemed panelists. So we have set an ambitious goal of delivering 8 new breakthroughs in cancer by the end of the decade. But we are in a race against cancer. We've made tremendous progress over recent decades, but cancer is racing against us, and we're seeing like an increased incidence of cancer, and particularly at an alarming rate in people in their prime, under 50 years old, which is not a time we would have thought about as being at risk of cancer in the past. And I'll share with you a personal example. I have a colleague and very dear friend, Lily, who just given birth to her second child. She's in her late 30s, had a pain in her side. Thankfully, it was not written off as a postpartum symptom, and it was further explored, and she was diagnosed with stage 3 colon cancer. And that's way before she would have been indicated for a colonoscopy. And so she's an example of this emerging face of cancer that's really quite challenging and quite alarming. So we've made a lot of progress. We're racing against cancer, seems to be trying to beat us in that race. So at Pfizer, with that bold goal of delivering 8 new breakthroughs by the end of the decade, so we have now committed 40% of our R&D research is solely focused on oncology. That is over 55 programs, about 30 new molecular entities, so potential new medicines that we're trying to explore as we move through this process. And we're studying some of the most commonly common cancers across the population, so breast, prostate, GU cancers, hematology, and lung cancer. And we're dedicating a really focused effort across 3 scientific modalities. So really trying to take on cancer and make an impact and hopefully deliver those 8 breakthroughs.
Yeah, I mean, I think that phenomenon of younger people and these diagnoses is something that I think is causing so much anxiety in the population. Dr. Bertagnolli, can you talk to us about the research aspect of this? I think a lot of people are wondering today, where are we headed as a country in terms of how we are funding and supporting the important medical research that we need in order to tackle cancer as a phenomenon? And talk to us about the beginning of that pipeline and where you see, with all the government cuts that we're about to experience, where you see that research funding coming from in the future.
So thrilled to be here. I want to start, though, with something, since we're on the theme of cancer, is I was the former director of the National Cancer Institute before I moved over to be the head of the National Institutes of Health. 5 weeks after becoming NCI director, I had a mammogram, and I found out I had cancer. Wow. I am now the director of the National Cancer Institute. I have breast cancer. I am fine. I went through all my treatment, and I am fine. But I will tell you, every single bit of the treatment I got was supported, funded, and happened because of the National Institutes of Health, the National Cancer Institute. Yay. And it's a really big topic you've given me. Let me just riff off of what the two have said and maybe talk about the unique contribution of our taxpayer dollars that go to funding research. 3 areas, because we want to be partners. You represent industry. You represent perhaps the academic world, you know, our big academic institutions like Memorial Sloan Kettering, Breaking Ground. What's the contribution of your taxpayer dollars? We want to leverage what these guys do. We want to work with them as partners, not duplicate. And there's 3 areas that NIH focuses on so as not to duplicate. The first is fundamental science, the real biology of how our bodies work so that we can understand why that breast cell turned into a cancer and why our bodies didn't just eliminate it like they are supposed to. When a bad cell pops up, believe it or not, when our bodies are working right, they just get rid of it. Why did that happen? That's deep, deep laboratory work. The second are the clinics. You know, how do we get these results, do these amazing contributions that come from working in the clinic and getting research out there and doing research directly in the clinics. But the third, and I think this is even a more important contribution today, is your biology, your disease is a combination of the genes you inherit from your parents, but it is also profoundly influenced by your environment. Where you grew up, what kind of food you had, did you get exercise, what's your educational attainment, frankly? Did you kind of know how to do the right things? What your social support network is like? You know, we know all these things profoundly influence health. So this is another part of what your taxpayer dollars do, is expand research into not just the laboratory, not just the clinic, but the communities, and understand how strong and healthy communities can work. So that's what NIH is focusing on.
Yeah, there's an aspect of that that I'm going to get to later, which is the aspect of health that is about the disparities that we see. It's based on who people are, where they come from, communities they live in. But Tina, if you could just piggyback off of that, talk to us about the next stage in the development process. How does Fizer build on what happens at NIH?
Yeah, no, it's a great question, and I do think it's the partnership across sort of the 3 areas that we represent is critical for us to ultimately be able to deliver those breakthroughs. I think one of the places I would highlight is in personalized medicine that you referenced and Monica, you touched upon, which is ultimately enabled by a fundamental understanding of the biology of the disease. And I'll give an example of this in lung cancer, which we all know tends to have a fairly challenging prognosis, particularly when diagnosed in the metastatic setting. But I'm going to share another patient story that I think brings this to life, with a patient that I'm happy to say we have a long-term relationship with at Fizer. His name is Matt, and about 14 years ago, he was diagnosed with metastatic lung cancer at a time when he would have been given a potentially less than a year to live. But because of the great research that had happened, we had a better fundamental understanding of that disease and know that it's actually a certain segment of lung cancer. It was called ALK positive, driven by a genetic mutation. And in that genetic mutation, we had been able to develop a targeted therapy against that because of that understanding. So I think that sort of illustrates, and of course we worked with institutions like Memorial Sloan Kettering to further explore that in clinical trials. So 14 years later, and actually I should say when he was diagnosed, Matt was a non-smoker and he was 24 years old. So really in the prime of his life. But 14 years later, happy to say we interacted with him recently. He has earned his doctorate, he got married, he has a daughter, and has a very positive outlook. But I think that example illustrates like how sort of the 3 sectors can work together to really make that real impact on patients' lives.
Yeah. And Dr. Ofadile, Memorial Sloan Kettering is a great institution. And I do think it matters where people are treated, what kind of care they get, whether they have access to personalized medicine. How are these developments being brought into the marketplace while also taking into consideration the need to flatten some of these disparities that we see across the spectrum when it comes to different kinds of cancers, and whether people who look like you and me have different outcomes than other segments of the population?
So before I respond, I'd like to react to a comment Monica said, which is right now we are in the midst of really exciting innovations in medicine, whether it's AI, single cell sequencing, and on and on and on. And I think the ability for places like MSK collaborating with funders like the NIH and developers like Fizer to get these innovations to the marketplace is really, really exciting. So to answer your question, we can actually now think about technologies, the right kind of technologies like AI, to democratize MSK's expertise, right? So in a perfect world, in a future world, not too far from now, how can we have physicians in rural America access information, insights that are typically housed in a place like MSK? I think the infrastructure exists today, and it's really a policy solution to get this out there. But I think AI has a huge role to play. Secondly, at MSK, we've thoughtfully created partnerships. So for instance, we partnered with Medicis Health System. It's a safety net hospital in Queens, New York, the largest safety net provider in Queens. And we're helping them build their cancer centers with our protocols, our pathways, in a mutually beneficial partnership to elevate their standards of care. So for patients in Queens who have cancer, they don't have to deal with the travel burden, the disruption to their lives to come to Manhattan to get care at MSK. With Queens Medicis Health System, we deliver care locally in their environment. So I'll say it's a blend of technology, democratizing expertise, as well as thoughtful partnerships to get care local, high quality care local.
I want to pivot for just a moment to talk a little bit about public health, just in general. Dr. Bertagnolli, you've been inside the federal infrastructure around public health, and you talked passionately about the power of taxpayer dollars. But I also think that there's a trust issue that we're facing as a country. And the COVID-19 pandemic that we just went through exacerbated that trust problem. So how do we rebuild? How do we rebuild a system that has people's trust and maybe learns from some of the mistakes that were made during the pandemic?
So I'm so glad you asked me this. Well, I can tell you there's one way we're not going to rebuild trust, and that's by public relations campaigns, or here's what you go, you have to, here's what you should do, or by experts coming and telling people what they should do. That's not the way we build trust. We build trust human being to human being. And this is why one of the things I am particularly passionate about is our public funding and our public health system getting into every single community. A couple reasons for that. Every community's different. Every person's different. Every community's different. It is really critical that we have people who have the bandwidth, the expertise, the connections, the connectivity into those communities to engage with that community. And you don't earn trust by saying, here's what you should do. You engage trust by saying, what do you need? What worries you? What bothers you? Because guess what? There is absolutely something in our research enterprise that can be offered to a person, and it's their desire and their investment that we engage them in. There's a program at NIH that I very much hope blossoms and continues. It's called Communities Advancing Research Equity for Health, or Care for Health. And this is exactly what it's doing. It's going into communities and saying, what's your biggest problem here? And we will bring research to help you solve that. I think that's how we earn trust.
Can I ask you though, that word, if you say the word equity these days in the federal government, I'm not sure that that would get you very far. Are we walking back an understanding of how communities and their differences impact people's health?
No, absolutely not. I mean, we have to, our federal government is here for everyone. Our federal government is not here for only Republicans or only Democrats or only one race or only another race or, only people who live in New York City. Our federal government truly is here for everyone. We have a representational government. I mean, I won't minimize the fact that there are a lot of challenging discussions going on right now, but the National Institutes of Health, Health and Human Services is here for everybody. And I'm not afraid of the word equity because that's what equity means. It means everybody.
Good to hear. Dr. Fidelia, if you want to weigh in on that and just share with us how it affects private institutions like your own.
So a few things. One is health equity is not zero sum. It's actually positive sum. So elevating the standards of care for all communities in the United States leads to a more productive workforce, overall lower healthcare spending, and more economic growth. So that's what we want. On the MSK side, what I'll say is, as an institution, we're 140 years old. We are really driven by some core values in our mission. And these missions are immutable across leadership teams, across presidential administration. Now, as an organization with 20,000 people, we are going to be productive and pragmatic with the government, but our values inform what we do and how we do it. So this idea of inclusive care for everyone is something we hold dear, and we are really committed to that across the entire organization. So cancer-related health equity, which persists today, is a problem. And that's a problem that touches us in direct and indirect ways. So trying to solve that through partnerships, democratizing our expertise, delivering care in a culturally competent manner, that's what we're committed to doing.
Tina, I want to give you an opportunity to weigh in on that too, because I think this is such a rich topic and it's timely right now. And I think every phase of the healthcare process, from the government to the private sector companies like Fizer to the facilities that treat people, are interacting with this. And how does Fizer approach that question?
So, we recognize that all the science innovation in the world and bringing innovative medicines doesn't matter unless we can actually get the medicines into the hands of patients that need them most. And we recognize some of the disparities we're talking about, and just a couple of examples that I think will resonate. We know that Black women are more likely to be diagnosed with breast cancer much later than their white counterparts. We know that 20% of Americans live more than 60 miles from an oncologist, making it hard to get equitable care. So our focus is try to reach all patients. And we also know we can't do that on our own, but we work in partnership across the community, the oncology community, to do so. And I'll highlight an example we have with the American Cancer Society, where we're in a collaboration with them on their Change the Odds initiative, which is designed to target underserved communities and try and improve the patient outcomes in those patient populations. It's emphasized screening, it emphasizes participation in clinical trials, which has historically been a gap, as well as just education to help patients navigate their journey. So we're looking to reach all patients, and we will collaborate with the community to make sure we're doing so across the board.
And what about cost? Cost is obviously, maybe it's the biggest factor in access to care. I think that there has been a conversation nationally in this country about how much it costs to save a life. How does Fizer think about that? And what are you all doing to address that concern?
Yeah. So restating again, we know that the innovation doesn't make make the difference unless we can get it into the hands of patients. And obviously, cost has multiple layers to it. What we're focused on is working with patients, working with oncology practices to help patients navigate their journey with insurance, support them with copay assistance, and then sometimes in the appropriate circumstances with free medicine. So we're very focused on how we work with the patient and their circumstance to try and help them navigate that situation.
Dr. Bertagnolli, let me talk for 1 second. We just have a few minutes left. about preventative care, because I think you alluded to that a little bit as you were talking about the environmental factors that go into a person developing cancer. A lot of it is genetic, some of it is environmental. People are so interested in what they can do to change their own health outcomes. I think that that is both powerful and important. But is the public health apparatus doing enough to educate people and about what they can do, and also to keep up with a desire? I think we just saw this a couple days ago, the synthetic dyes, they're being banned, right? And I know that the science is a little bit more inconclusive, but the public seemed to really want something to be done about this. So is the public health community really meeting people where they are to get ahead of some concerns that people have about how they can take control of their own health?
We can do so much more there. And actually, this is one of the most exciting times, I think. First of all, there's been a lot, we've spent a lot of our healthcare dollars attacking disease. That's where our focus has gone. Somebody's hurt, they're in trouble, let's do that right now. We have not, frankly, spent as much time, money, as I think we could on understanding the fundamentals of prevention. So you give an example. Do we have those data yet? No. Can we get those data? Absolutely, especially now with the tools that we have, with the new information technology tools we have, with the data analytics and artificial intelligence methods. Can we learn from the biggest, broadest possible population to put those puzzle pieces together to really bring science and data to how guidelines for how people can live a long and healthy life? I really believe that we can. And that's what it's going to take, frankly, because it's that big of a problem. The other reason I'm optimistic about this, and you alluded to it, it's going to take engaging everybody in this process. This is not a solution that we can solve just by the people who walk into Memorial Sloan Kettering's door. This is a solution that's going to take being a connected, learning health system. This is one of my big passions, is creating a learning health system so that everybody can contribute to the knowledge that will let us know what we need to do, and everybody will want to do it because you've all been part of finding the answers.
And Dr. Avadila, take us out on a positive note, because I do think that the future on science and AI is so bright and exciting.
Yeah.
So what are you the most excited by that AI can do for us in the future?
So I'm really excited by cancer vaccines, actually.
Wow.
So this is vaccines not for prevention, but actually for treatment. So pancreatic cancer is a very tough cancer.
Mention later.
10% of people live more than 5 years, abysmal rates. What we're doing at Sloan Kettering is now using AI to pick out of your pancreatic cancer, what are the unique driver mutations, what are unique proteins that are associated with your cancer, and on the back end of that, creating mRNA vaccines targeted to that specific cancer. So it's an N-of-1 therapy. And we did that, published our results last year, and what we found is for people who responded, so their body created a protein trigger after the vaccine, they had continued survival 3 years out. That's incredibly fascinating. And think about what that means for taking this from pancreatic cancer to other tough-to-treat cancers. So mRNA vaccines, incredibly exciting. That involves AI to pick the mutations, and that involves a new platform we learned with COVID, mRNA vaccines. That is incredibly exciting.
It's incredibly exciting. Thank you all so much for the work that you do. Thank you.